Hello and welcome to the NLP View. My name is Donna Blinston. On today's show, I am joined by Mark Peters, who is an NLP master practitioner, a hypnotherapist, CBT therapist, life coach and rehabilitation trainer. Neuro-linguistic programming, NLP, is primarily about communication, looking into how the language we use affects our mind and behaviour. NLP provides both an insight and understanding into how we think and how we can use a language that we choose to use to positively impact the person we're speaking with. In healthcare, we're not only involved personally in a complex organisation, and our own busy lives within the NHS or within whichever healthcare private sector, but we're also involved in other people's lives and often at a time when they're most vulnerable. On today's show, I will be discussing with Mark Peters how we can use NLP to enhance our personal communication and also how we can really listen to what our patients are saying, enabling the medical professional to communicate even more effectively and becoming aware of how the language they use can impact on their patients. So I'd like to welcome to the show Mark Peters. Hello, Mark.
Yeah, hi, Donna.
Hello, how are you?
Yeah, very well. Looking forward to this. You can hear my clock chiming in the background. It's that time.
We must have hit 7 o'clock then.
Yes, that's correct.
Is that a lovely tall grandfather clock?
Yes, it is. Yeah, from 1710.
Very nice, very nice. So, Mark, could you tell our listeners, how did you get involved with NLP? And really, a bit about yourself and your background.
Okay, well, originally, I was an operations director, and I was reorganising an organisation at the time, and I came across NLP, the Management of Change. I read this book, and I thought, God, this is fantastic, and I started to use aspects of it, whether it be the map is not a territory, listening to people's language structure, just simple basics, and I was amazed at the effect that it would have with people. And from there, I decided to train in NLP. My wife was a practice nurse, and she'd introduced me to hypnotherapy through Dudley Road Hospital in Birmingham, and she was using it with patients. And then I started to look at how the structure of language, consciously and unconscious, can have an impact. Yeah. Now, I must admit, my first usage was in Management of Change, and then my next usage was that I've been teaching Tai Chi for well over 20 years now, so I started to use it in a class to find what impact it would have on students that said they couldn't learn things. I found they could learn things much quicker, much easier.
Yes.
Once I changed my approach to listening to what they did and responding in accordingly. From there I trained with the Rich Bandler, through Society of NLP, up to Master Practitioner, and currently training as a trainer.
Wow. That is quite a background. And it's nice to see how you've adapted it as you've developed, and you've brought in other aspects. What was it that brought you into using it alongside your wife being a practice nurse? But what got you into using it more so in the healthcare field?
Well, initially, when I was asked to do a program of Tai Chi for falls prevention, we were using the Tai Chi movements, and then we were finding that it wasn't just a physical aspect, it was a psychological aspect. It was the fear of falling that was causing more problems than the physical aspect of falling itself. So I used a change in motivation, a change in belief through the structure of NLP, through presuppositions and truisms, embedded questions, which I'll discuss later, and embedded commands. And then that moved on, because it had such a big impact, it moved on to COPD, which is chronic obstructive pulmonary disease for lung conditions, and then heart failure, so cardiac rehab and cardiac CHF. I've just been surprised how widely. My initial response was to use it as an adjunct to Tai Chi, but then I found that people's beliefs are so powerful that it became more than just a physical aspect of it. It was a psychological aspect of what they believed could happen, what they felt might happen based on past experience. And if I was able to change that sort of mind-made movie, that schema that took them where they were, then I could have an impact. And to see that change, and to train physios and OTs and various allied health professionals became my next direction, to the point where actually I quit my job and focused on what I might call now human engineering, or even lean mind management. The NHS in the UK have got heavily into lean, which is from a manufacturing area first. So I see NLP as lean mind management, as taking away the chaff and cutting out necessary.
Yeah.
Yes, sir.
It is. I mean, NLP, as you know myself, I'm a nurse. I work both on intensive care and as a bloodborne viruses nurse specialist. And I use NLP every day, whether I'm doing it formally or more so on a linguistic side. And I guess for me it's very much being aware of my own language and my behaviours and how I'm interacting with other people, but also my impact particularly on the patients and listening to what it is they're saying. And I guess I'm explaining this because of how you explain about beliefs. Because when we think from a logical levels point of view, we're often dealing with patients, looking at their behaviours, their capabilities, in their home environment or in the nursing environment of what they can and can't do. Yet if at a belief level, which is higher than capabilities and behaviours from a logical levels perspective, if they don't believe they can do it, it doesn't matter how many times we teach them a skill, they're not going to be able to do it. And I think that's where the listening comes in, is listening to what they're actually saying and how they're saying it and where the problem's lying for them. Yeah.
I mean, from a belief, then they move on to their identity, who they believe they are. I'm an ill person, I'm a frail person, I'm a weak person. And they create that identity, and then that gets supported by the environment, and it gets supported by even beyond self. It gets supported by the next level, by the carers, where people overcare and create this sort of learned helplessness process. But if you can change someone's belief, you can change their behaviour. I remember reading there's some statistics that said if people fall, they're more likely at falling again. If they fall more than twice, they're more likely it's hospitalisation. These are average stats. They're not truths. They're not facts. But if people tell you that, then you start to believe that.
And you wait for the next time you're going to fall. You're on an edge, and you hold yourself differently. You're consciously thinking all the time, I've got to be careful, I'm not going to fall, I've got to be careful, to watch what I'm stepping on. And because you're so focused on the floor or your foot, you're not looking at what's ahead of you. And you see that so often, especially with elderly people with walking sticks or walking frames. There is focused on what the Zimmer frame is doing, and the walking stick, and getting the feet in the right places, because they don't want to fall, which they've been told they're going to because they fell before. That's all. It brings back to the what's the saying? What you attract.
Oh yeah, it's what you focus on. You become like an exert missile. It's what you focus on is what you get. I know one of my friends who's a police officer said when they teach advanced driving, the first thing they have to do is learn to focus on the gap. Most people focus on the target, like the vehicle pulling out or the thing they're trying to avoid. But whatever you focus on is what you get. So they need to learn to focus on the gap, not the element they're trying to avoid. And I know when I was a kid, we used to tell our friends when we played football, careful don't bump into the post. Because damn well they would bump into the post. And once you learn to focus on what you want to achieve, not what you want to avoid, to have a clear outcome of what you want, to have a well-formed outcome in NLP terms, you get a clearer effect. When you focus on what you don't want, what you do is you give yourself a negative command. Don't think about this, I mustn't do that. And you just keep reinforcing it. You know yourself, I mean, it's been icy weather recently. And what happens when people try not to fall over, they focus on the ice, stiffen up, become imbalanced, and fall over. It's just madness.
I've met many of them this winter already. many.
Yeah.
Some nasty falls.
Yeah, I can appreciate that. What jumps to mind is a quote by Einstein, and he said, "You can't use the same thinking to fix the problem that created the problem in the first place." And this is where really NLP comes in. People say, "I can't because," and they base it on the evidence they've got. Well, you can't overcome a problem with the same problem thinking. And you can take a reframe of language, listening to how people are saying things, to questioning what they believe, to understanding their generalizations, their deletions and distortions, even at a simple level, to reframe that and to change that to something more useful.
And often just to ask them, what if they could?
Yeah,
absolutely. What if you could do? It's one thing that I'm phenomenally, continuously saying at work, especially with my BBV patients, asking them, what if you could do it? Could you act as if you can do it? How would things be different if you're able to do it? And as soon as they start moving into that mindset of being able to and acting as if they've done it, then you can say, so what is it that you're doing differently now in this place where you've done it that you're not doing currently? And just playing around with their language and their focus. Oh yeah,
absolutely. I remember when I first learned NLP sleight of mouth patterns, and we talked about if frames and acceptance frames. An if frame, what if? People say, I can't because. Well, if you could, where would you start?
Yeah.
As soon as you start to use a simple word like if, they have to create a possibility, and it overcomes limits of failure. Our experience to date has been pass or fail. Exams, jobs, promotions, pass or fail, win or fail. But as soon as you use a word like if, it gives a possibility. If only, what if? And then there's no risk of failure because you're not risking challenge. And it's surprising when you say to someone, if you could do this, where would you start? If you did this differently, how would you go about it? And because you take away that risk of failure, it makes such a massive difference.
It does, and it's lovely to see, because you're watching how you're shaking their. Whenever anyone's got a problem, they've kind of got it they've kind of put a box and a frame, and they've proved to themselves that they have this problem, and they hold on to it pretty damn tight.
Yeah.
And just by using the what ifs, you can literally see how you're starting to shake the frame of that box and make it bigger and mold it.
Yeah.
And the bigger it goes, the more options and the more different ways that people can go with it.
Yeah.
It does open so many doors.
Oh, it does. I know when I was a young lad and I was watching Saturday morning TV, we used to watch swashbuckling movies and Errol Flynn and all that sort of stuff. I give away my age now. But even if you think the Pirates of the Caribbean and the newer movies with Johnny Depp, when they get the map out, the world was flat, and at the edge of the map, you would say there'd be dragons. But the reason there was dragons is because people didn't come back or because they didn't know what was there. And the first time somebody came back and said, well, actually, there was the Caribbeans, and it was beautiful, and I got a suntan, I'm going next year, then they rub the dragons out, and then there's the Americas. And suddenly there's not dragons, there's possibilities.
Yeah.
But that widens people's maps of reality. Now, unfortunately, what tends to happen is a patient that you're working with tells you, I can't because, and that's their limit of their map. And we as clinicians try to help by saying that's not true. But in effect, we're unconsciously saying you're a liar. We don't mean to say that. It's not intentional. But we're telling people their map is not true. Now, it's much softer, much nicer if you say, I accept your map, I accept your current belief. But while we're doing this, if I added this map to it, if I added these parts and unfolded these pages to give you other possibilities, you could test these as you will until you find a better route. Then you can choose to let go of the old map. Now, it takes a skillful language. It's not difficult. It just takes an approach that's not about I'm right, you're wrong. It's about, well, I accept what you're saying, and have you considered this? which helps widen someone's maps and possibilities. And it's amazing to see people who say, I can't breathe because of my COPD, I can't walk because I fall and because I'm old, I can't breathe because of my heart failure. All these things, when you're suddenly saying disability means an inability to do that a certain way. What other way could you do it if you thought about it? And it's amazing. Simple changes in language structure. A friend of mine teaches consultation skills, and we're discussing this as a night. I was going through the various models of consultation skills. I said, did you realise when you were discussing that then that you started tensing it in current tense all of the time? What is the problem you are having? How is it affecting you? How will it be affecting you? Rather than simply saying, what is the problem you had? How was it affecting you? What would you like to have happen? Just changing past, current and future tense is not negating the value of consultation skills. It's just, I suppose, making them leaner and cleaner, making them more linguistically relevant. Considering an issue as a past tense and what they were discussing now as a current tense and what they want to achieve as a future tense is a very simple thing that we do in our language. But if we're not mindful of it, it's very easy to keep some people in a bad place.
It's very easy, and it happens so often. And I think a mix with that is, I mean, as we're obliged to tell people their the possible risks with it, or if anyone asks for the prognosis, or how what the chances having a spine operation, for example, and what are the chances of being able to walk again. If the depending on what tense the doctor is explaining things in, if they say that only 1 or 2% will be able to walk again, or people that he's seen in the past still can't walk today, he's placing almost a blanket over that the rest of that person's map and limiting it even further for them. When it might be true that only 1 or 2% might survive and walk as they were today following that operation, but it doesn't mean that that person isn't that 1 or 2%.
Absolutely.
It's often how the doctor explains it, and I don't mean for the doctor to lie or withhold information, because we can't do it. We're duty bound to give the accurate information, but it's the way that it's put across. And if we were just to be able to have it in past tense of the doctor's past experience, explain some of the positives that he's seen in the future, then we can change and keep that map open, so that when that person has had the surgery, their map isn't closed before physically it ends up being closed, possibly from whatever happens post-surgery. Yeah,
you've hit that perfectly. We should not close someone's map. I mean, all things are possible. I was reading an article today in the Mail about a lady with MS who was told how her life would degrade and how it continues to, as the condition evolves, how mobility and ability would continue to degrade. And she was 25. As I read through this article, she said, I'm now 41. I'm walking in high heels. I am out and about. I'm talking, writing, discussing. As it happens, I've been diagnosed now with benign MS, but you can't know that until after, because benign is an after diagnosis, not a pre-diagnosis. Yeah. But when you close someone's map at the beginning, you've closed possibility. If you can keep enabling possibility, it's not that you're creating false hope, it's that you're enabling possibility. And even if you say, well, from your perspective, what do you feel would be an acceptable level of mobility, or what do you believe is possible? You get some more clarity of their map of reality, and the communication is key. Meaning of communication is in a response that you get. If you close down someone's map, if you tell them what your current beliefs and values are, they'll hear what they hear, not what you say, but what they believe from their current perspective and understanding. It's not wrong, it's not right, it's just how human nature is and how we're designed as human beings. If you can open someone's map and enable possibility, then evidence will present itself, and you just give continued support. Completely. I couldn't agree more. I can't agree more. Okay. You've said one of my
second, other than the map is not the territory, one of my second favourite, I guess, presuppositions of NLP is that of in the communication is the response you get. So the meaning of communication is response you get. And it's one that I hold very dear. And I guess it's because I hear so often, whether it be from other nurses or other medical professionals, of how somebody is stupid, dumb, sick, a whole selection of negative connotations, really, because what the professional has said to them they've not understood, or they've not got the response back that they expected. And I've got this knee-jerk then response of how the meaning of communication is the response you get. So if you know that person's struggling to understand what you've said, and you've left it with their thick and they don't understand it, then surely it's actually the person that's the thick one, if you will. Because if they knew that and they've not been able to adapt their own language, be flexible enough with their communication to enable that person to understand what they're saying, then it's their communication that's in error. It's them that is not being able to open up the map. It's not being able to, I suppose, be the professional, be the one who needs to be the support. And that, I think, if that was something, that and the respecting the person's model of the world, which we've touched briefly, I think if those presuppositions were taken on board, and even if it was just for a month or a couple of weeks or a month, and really embodied by medical staff from every field, from the domestics right up to the chief exec, just to see how it makes it different for them, how much more success they have, and how the patients react differently, I'm sure it would completely transform the way healthcare works and the outcome for the patients.
Well, just to paraphrase another presupposition, there's no inflexible patients. There's no difficult patients. There's no difficult patients, just inflexible clinicians.
Completely.
And I was on a train a few months ago, and I remember seeing a poster advertising cervical smears. I don't know if you've seen the one with the pictures of pants and knickers, rather, and it says cervical smears pants. And the bit that caught me, because you mentioned presuppositions, is cervical smears can be simple and can be performed in your GP surgery or medical centre in private. Now, people don't realise that presupposes that it can be also done in public, and it's not intentional. But once you realise that it's very easy to presuppose things in the structure of language, it doesn't matter what you believe when you say it. It's what is heard by the other person. I've got an old advertising poster in my house for Boots Chemist, and it says Boots Chemists provides pure and fresh drugs. No, that advertising poster was when Boots was a different organisation and drugs meant a different thing. But it's presupposing a statement, and I do find it quite amusing. And I've used it in a lecture a few times, and I've actually taken a photograph of that on the train station and the train to realise that what does pure and fresh drugs now? What does be done in private mean now? We have to realise it's not what we say; it's what is heard and believed by the other person when we say things.
Yes.
More and more we learn to presuppose and directionalise our language, to use things like truisms and embedded commands, embedded questions, makes such a massive impact. Presupposing what is it someone expects, how much better would you like to be, presupposing that an improvement is possible. How different would you like it to be than it is now, presupposing that a difference is possible. All these happen rather than presupposing, now I know you've struggled and it might be hard, do you think it's possible to make a difference? It's just suggesting the wrong direction. That's an embedded question that presupposes failure. When if you said, would you like to do this or this, would you like to be this more mobile or that more painless, gives more clarity of direction. It's not a hard thing, it's not involved. It's not you're asking someone to do a difficult, involved therapeutic technique and become a fully qualified psychologist or physical therapist or psychotherapist, counsellor. you're just asking people to be a little bit more considered and directionalized in the language. And that, as you said, if people tried it for a week or tried it for a month and realised the impact of saying, how can I help you, rather than what is wrong, it has such an impact.
Oh, it does. When I did my diploma back in January of 2005, we were invited to play that game, and I'm still playing it, and I will never go back to not playing it, because it's transformed everything, and the success of the patients, my relationships, my ability to build rapport with the patients.
Yeah.
And I guess it's the whole thing about really listening to what's been said, what they're saying and what isn't being said. And from using your language, as you say, more considered, you can start to be more aware of where those gaps are. What is it that must be happening for that other person? It's that being able to step back and say, okay, so what must be going on? Because if they can't imagine themselves being better, if they can't imagine themselves being pain-free, then they're either holding on to being ill or holding on to the pain for their own reason, their own secondary gain, or they don't believe that they can. And as a healthcare professional, I think we have a duty to be able to fully support our patients. We all talk about holistic assessments and the spiritual and every part of their being, and what's going on for them psychologically impacts on every single sector. So surely, just by considering our language more effectively, listening to what's actually being said, it's not doing any interventions. It's just opening up possibilities and opening up the doors that are there, but have just, some people they're ajar and some people are completely closed.
Yeah. We do it ourselves. Someone says, I am in pain, and we presuppose against our own measure what pain is, instead of saying what kind of pain is pain. When I am anxious, what kind of anxious is anxious? We never ask those questions. We presume it against our own measure. Yeah. And that's human nature.
How is it affecting you?
Yes, absolutely. I would suggest, I remember reading some Clean Language, which is a bit of a spin-off by David Groven, a psychologist, but closely related to NLP. He said, his Clean Language 12 questions, one of them is motivating the moment, and I quite like the structure, and it is, what would you like to have happen? And then people might say, and then you say, and what would you need to have happen for that to happen?
Yeah.
And then they'll say, and then is there anything else that needs to happen? And then you can just move them through that little loop. And then when you've got to the point, is there anything else? And they say no, you can say, and can you do it? And will you do it? Now that little loop of 5 questions moves people forward so quickly, because what would you like to have happen? I would like to be pain-free. And what would you like to need for that? What would need to be for that to happen? And is that possible? You can start to get them to put in context and think differently, and then move forward from there.
Mark, I could talk to you about this forever.
Yeah.
Well, I'm conscious of the time. Our half an hour has flown by. Could you tell our audience how they can get in contact with you and give your website details for me?
Okay. Yes, my website is balancedapproach.co.uk. And that focuses on my NLP and coaching and hypnosis training. Or even if you're interested in Tai Chi, you could look at midlandstaichirehab.com, which will look at how I'm using Tai Chi and NLP in terms of patient physical rehab, psychological rehab. I'm based in Birmingham, in the West Midlands, and I look forward to hearing from you, from your readers and from your listeners. Thank you.
Thank you, Mark. It's been brilliant having you on the show today.